Hi students! In this week's videos we're going to be talking about content that comes from Chapter 3. And here's a plan for what we will be covering. We will be talking about phases of a behavior modification program. We'll be talking about behavioral assessment, whether we're going to do indirect or direct procedures, why it's important to collect data, how to collect data, which specific characteristics should we observe, how often should we observe, and other considerations. So this is the plan that we will be covering across the next set of videos. So let's go ahead and get started. The first thing we're going to be talking about are the 5 phases that take place in all behavior modification programs. Now in this slide I'm telling you what the 5 phases are, and in the next slide I'm going to be walking through the details of each of these phases. The first phase is some kind of a screening intake, where we collect data on the individual. The second phase has to do with defining the target behavior, identifying what the behaviors are to be modified. The third phase has to do with baseline, collecting data regarding how often the target behavior and any other behaviors are occurring before any kind of a treatment. The fourth phase has to do with treatment, intervention, and the fifth phase has to do with following up, seeing what happens after the treatment. So we're going to talk about each of these components in a little bit more detail now. So in terms of the first phase, screening and intake, it's during this phase that the clinician or the behavior modifier is working with the client to figure out what is the problem, what is the behavior that needs to be changed. During this time, the clinician's trying to figure out, is this a behavior that is possible to modify? Now, it's not that some behaviors can be modified or not, but different clinicians, different behavior modifiers have different levels of expertise with different kinds of behaviors. And so, at this point, the clinician or the therapist is trying to figure out, is this a behavior that I am skilled enough to modify? During this time, the clinician's also trying to screen for crisis. Is the person coming in engaged in behaviors that are putting this person at risk for physical or mental challenges? Is this person depressed? Is this person at risk for harming themselves? If the person is at risk for crisis, they need immediate intervention, then other steps may need to be taken. So what we're going to see when we go through these different phases of behavior modification is that there's oftentimes there's a longer time frame because we're trying to figure out what's happening with regard to the behavior. If this is a crisis behavior, we need to take immediate action and different steps must be taken. It's during this time that the clinician is trying to collect enough information to form a diagnosis. Now, by diagnosis, I mean some kind of a label. How would we classify this individual's behavior? Now, if you're remembering videos from last week, you might be thinking, now wait a minute, behavior modifiers don't typically use labels. But to some extent, depending upon what's going on with this individual, that's important. It's important to come up with some kind of a label, some kind of a diagnosis, I should say. So now, again, the clinician is not interested in a label, but trying to figure out which behaviors are needed to be modified. Also, depending upon what's happening with respect to insurance, a diagnosis may be needed for treatment to proceed. So oftentimes with respect to insurance, some kind of a diagnosis has to be determined, a label has to be put forward so that the treatment plan can proceed and certain behaviors can be modified. It also might suggest specific behaviors for modification. So the diagnosis may come along with specific behaviors, and then the clinician knows what needs to be targeted for the intervention. The second phase of all behavior modification programs has to do with defining the target behavior. Now, this is the behavior that the clinician and the client are working on to change. In your own research projects, this is going to be the behavior that you decide to change. So the clinician is trying to determine, is this a behavioral excess, something that happens too much, or is it a behavioral deficit, something that doesn't happen enough? And it's at this point that they're trying to come up with an operational definition of the target behavior. This is deciding how will this behavior be measured? What exactly counts as this target behavior? The next phase is baseline, and this is assessing the target behavior before any kind of a treatment. So you're going to see in this class that treatment is oftentimes abbreviated as TX. So during baseline, the clinician and the client are really looking at the target behavior and trying to determine, is this an excess? Is it a deficit? Now this is important. It's important to collect data during baseline because sometimes we think that something might be an excess or a deficit, but when we collect data on it, when we really measure what's happening, we determine that it's not an excess or a deficit. This has happened in this class in the past. I had a student that was really interested in decreasing the amount of TV watching that was occurring. The student believed that that was an excess. Well, when baseline occurred, the student determined that she was really only watching about an hour of television programming a day, and it wasn't interfering with her ability to complete schoolwork or interact with her friends. And so she went into the project thinking it was an excess, but when she collected data, she determined that it really wasn't. So this is what's important about baseline, really getting a sense about where is the behavior before any kind of a treatment. It's also important during baseline to be thinking about what are the antecedents, what happens before the behavior, are there specific triggers, and what are the consequences? Is this behavior reinforced? Is it being punished? So it's important to figure out what's happening before and what's happening after. The fourth phase has to do with treatment, the intervention. And it's during this time that we are modifying the antecedents, whatever the triggers are, and the consequences to see if we can either increase the behavior or decrease it. And we're measuring changes. And the last phase is considered the follow-up phase, and we're trying to see, did the treatment have an effect? And do the changes last? Okay, now we've gone through all of these different phases, but I want to show you an example of all of these phases in a real life research project that's happened in the past. So this comes from a publication done by McNamara, and he did this in 1970. So it's an older study, but I think it's really good because it goes through the details of all of these behavior modification phases. So in this particular study, there was a 6-year-old boy who was in preschool still. And during screening intake, this happened at the school, and during these observations, it was determined that the boy was very physically aggressive, and this meant engaging in a lot of hitting and kicking behavior, and this happened with other peers. So this was considered a behavioral excess. It was happening too often. Additionally, this 6-year-old was also engaging in pro-social behavior, in sharing and in turn-taking, and this was identified as a behavior, but this was happening at very low levels. So this was a deficit. So during the screening intake, they determined that they wanted to decrease the physically aggressive behavior. This was an excess, and they wanted to increase the pro-social behavior. This was a deficit. Now, during intake, they also did observations of the child at home, and it's important to kind of understand what the home situation was. So this was a child that was the third child of 6 children, so this is a big family, and the children that were older siblings were currently engaged in trouble with the law. So they were having run-ins with the law, they had criminal records. The mom was a single parent, and it was clear that this parent was stretched very thin. She was overwhelmed with trying to take care of with the older siblings, very focused on the older siblings, and likely didn't have a lot of time for this 6-year-old at home. So this 6-year-old was, there was minimal supervision for this 6-year-old at home. All right, so during the screening intake, this is the information that was collected. So in terms of defining the target behavior, based on the screening intake and observations from home and at school, the McNamara determined that aggressive behaviors, the hitting and the kicking, those were excesses, and was going to target trying to decrease these behaviors. And then the pro-social behaviors, the sharing and the turn-taking, those were deficits, and was going to try to focus on increasing those deficits. So in terms of baseline, they observed this child's behavior at school, and they observed the target behaviors at school for a week. And during that time, they determined that there were approximately 3 aggressive behaviors happening per day. So 3 instances of hitting and kicking that were happening during the day. And determined that the antecedents, this hitting and the kicking, was happening typically during conflict situations where there was another child asking the child for something, trying to take something away from the child. So the antecedents were different kinds of conflict situations. And the consequences of these aggressive behaviors were an increase in teachers' attention. And so it's possible that this teacher's attention was reinforcing these aggressive behaviors. So they also observed the prosocial behaviors. Now remember, these were the deficits, and they found that the prosocial behavior was happening on average about once a week. It only happened once during the week that they observed. So the antecedents for the prosocial behavior were a collaborative activity, something where the other peers in class were encouraged to be working together on something. And the consequence for this appeared that it was very reinforcing to be having fun with peers. So after baseline, they proceeded with the treatment, and the treatment involved an intervention that happened at school. So McNamara developed what he called prosocial training with peers, and so it involved the child and 3 peers, and they did an activity that they called picture games. That's what they called it with the children. So they presented the children in these small groups, so the child and 3 peers, with some open-ended pictures, and the open-ended pictures came from prior research. And they were prompting, and he prompted the child, how would you handle this? So asked the child as well as the peers. So here's examples of what the pictures look like. This is one picture that had a bunch of chimpanzees and they're having a conversation, and this looks like maybe a parent, and this is a child. And then here's another one where we've got some bears and they're doing kind of a tug of war. So the children are each prompted with how would you handle this? Now any kind of a non-aggressive response, so I would share, I would talk, I would ask for help, that was praised and reinforced. Any kind of an aggressive response, well, I would push, I would shove, I would grab that. They were prompted with, can you think of something else? Now this happened for the child as well as the 3 peers. So this provides opportunities for the child to see the peers modeling appropriate behavior, for the non-aggressive and the prosocial behaviors to be praised and reinforced, and the aggressive behaviors not to be given attention but to be prompted to come up with something else. So first this was done verbally. Then they shifted to a week of behavioral acting it out. So again, they were shown different pictures, not the exact same ones, but very similar pictures, and asked how would you handle this? And for any kind of a non-aggressive response, they were praised, and any kind of aggressive response, they were prompted, can you think of something else? So after the treatment, they assessed. Well, actually during treatment they assessed, and what they found was that they were observing the child outside of the treatment, so just happening within the classroom, and they found that the child was engaging in only 2 aggressive behaviors per week. Now remember, at baseline this child was engaged in 3 aggressive behaviors a day, so this is a substantial decrease. Additionally, the child was engaged in 1 prosocial behavior a day, and in the past this was 1 per week. So it at least appeared as if the aggressive behaviors were going down and the prosocial behaviors were going up. Now follow up. A month later, they were looking at what was happening with the aggressive behaviors and the prosocial behaviors. Now the prosocial training with the peers had ended. But what McNamara discovered was that there are many natural reinforcers in place. So the prosocial behavior with peers was being reinforced by both the peers and the teacher. So the prosocial behaviors were occurring at a high rate. And the aggressive behaviors were not happening at a high rate because they had been replaced by the prosocial behaviors. So essentially, this particular child was being reinforced for engaging in prosocial behaviors and not reinforced for aggressive behaviors. So the aggressive behaviors had gone down. And at home, also, McNamara observed that the mom was noting changes in the child's behavior and was engaged in praising the prosocial behavior as well too. So she had noticed that the aggressive behaviors had also gone down at home, and that's probably because she was reinforcing her child for engaging in more prosocial behaviors. Now, it's important to note that McNamara didn't do any kind of a treatment here at the home. It wasn't something that was possible to be happening at home with this particular child. But notice that this had kind of generalized to what was happening at home as well too. So McNamara concluded that this was a successful behavior modification intervention. Okay, so we're going to go ahead and take a break.